Hi, my name is Dr. Adarsh Thaker, and I'm a gastroenterologist and interventional endoscopist at UCLA Health. Today, I'm going to talk about endoscopic bariatric therapies or bariatric endoscopy procedures, which are minimally invasive techniques to help you achieve weight loss. These procedures include the endoscopic sleeve gastroplasty or ESG procedure, the gastric bypass revision, also known as a TORE procedure for patients who have already had a history of gastric bypass surgery, and then I'll briefly mention intragastric balloons and some of the newer therapies that are available for weight loss. There's going to be kind of 5 different themes that I'm going to hit on over and over again throughout this talk. And the first is that obesity is a major problem and it's getting worse. The second is that there is a treatment gap. And the fact of the matter is that there's many people that have extra weight. They're struggling with weight loss, and we are not treating them. If we consider obesity a medical condition, we have very good treatments, but we're reaching the minority of people. Third is that diet and exercise, and what we know mostly to be the most kind of fundamental, what most people will try, are fundamental. But more so than that, I would argue that behavior change is the most important aspect of that, and we'll talk about that. Fourth is that a multidisciplinary team, meaning multiple partners, including physicians, people around you, it's a team that succeeds in achieving weight loss. And we're going to talk about who those members of your team might be. And then finally, there's safe and effective therapies that are already here, but there are more coming soon. And I'll give you a little bit of a look into the future. When we talk about procedural interventions for obesity, there's a few different mechanisms that I'm going to highlight here, and you'll kind of see how each different procedure attacks one of these mechanisms. The first is what we call a restrictive mechanism. And so when we're talking about restrictive, we are talking about just physically not able to take, not being able to take more calories in by mouth. This results in you feeling full earlier, and it may actually adjust the hormone signals in your body, so you might have reduced hunger as well. The second main mechanism of weight loss is what we call malabsorption. So you limit the calorie utilization by your body. And so this may be that something like a bariatric surgery that we're going to discuss soon. And this results in regulation of your appetite signals and also regulation of your metabolism. And so probably the procedures that affect both of these, the restrictive and malabsorptive, that are most well known are the bariatric surgeries. And a very common, very effective, and very durable bariatric surgery is what we call the Roux-en-Y gastric bypass. So looking here at this diagram, this is what your esophagus and your stomach look like as if I'm looking at you from the front. And what the bariatric surgery does is it takes this stomach and it divides it into a small pouch, and then the leftover part is bypassed. It then takes the small intestine, which is responsible for a lot of the regulation of your metabolic hormones and also your glycemic controls, which is responsible for diabetes. Very, very important, this first part of the small intestine. And so what the Roux-en-Y gastric bypass does is it actually bypasses all of this. And so a part of your intestine is connected directly to the pouch. And this results in a restrictive component because of the pouch, and then a malabsorptive component because this part of the small intestine is actually bypassed. And so this surgery actually hits on both of those mechanisms that I just discussed. A second alternative surgery, which just does the restrictive component, is what we call the gastric sleeve surgery or laparoscopic sleeve gastrectomy. And in this procedure, the stomach is actually stapled along its greater curve right here, and actually a portion of the stomach is removed. And this results in a sleeve or a tube-like shape, which is important as we talk about the endoscopic therapies in a few minutes. So this is the second surgery. This does not have the malabsorptive component that the gastric bypass does, but still very effective by way of restricting the amount that you can eat. Now, surgery is effective. These surgeries have been shown to have 28 to 30% of your total body weight loss. They're durable. And they, as we mentioned, they restrict the amount of food you take. And then in the case of gastric bypass, it also limits the absorption of nutrients. You're taking in and absorbing less calories. In order to undergo surgery, there's kind of a rigorous program where you'll have a psychological assessment, medical assessment, anesthesia risk assessment. And it's done in that kind of team-based approach where you'll have a dietitian and others that will help you get to the surgery. Now, who can qualify for bariatric surgery? Well, we're talking about patients that have a body mass index of greater than 40, or in select cases, 35 with an obesity-related medical condition. So maybe diabetes or something similar to that. You need to be healthy enough for surgery. So if you're too sick, it may not be the right thing for you. And it's safe, but something to discuss with your surgeon is what are the short and long-term complications and effects. And I would still consider this the gold standard. It's a very effective means for achieving weight loss. And if you have these qualifications and came to me interested in an endoscopic therapy, I would definitely have you consider whether you should meet with a surgeon first to see if surgery is more appropriate for you. And so when we look back again to kind of the invasiveness and aggressiveness and the weight loss with our fundamental of diet and exercise, which really should be fundamental to any of these other therapies, next step up would be pharmaceuticals. Bariatric surgery really is kind of the top, but it may be too aggressive or not right for some people. And others may not qualify for it. And again, less than 1% of people who do qualify are even able to get it. And so we have a large treatment gap, and that's where endoscopic therapies have been developed to try to fill this gap between the lifestyle and medical therapies and weight loss surgeries. And so turning now to endoscopy, which is what I perform, an endoscopy, for those that are not familiar, it means that we're going through the mouth and there are no incisions on the outside. And we use a long tube that has a camera at the end of it, and we can control it with the handle here. It's typically an outpatient procedure and it's done under anesthesia, but we don't have to, the advantage over surgery is that because there's no cuts, the recovery is very fast. And so when we're talking about endoscopic bariatric therapies, there's two that I'm going to focus on today. One of them is called the endoscopic sleeve gastroplasty, which is a procedure for someone who has never had a weight loss procedure before. The second is what we call a gastric bypass revision. Another name for it is the transoral outlet reduction. And then third is going to be, I'll briefly touch upon gastric balloons, and then look a little bit into the future on what comes next after that. These endoscopic bariatric therapies are newer. They're minimally invasive procedures. As I mentioned, they require no incisions on the outside as opposed to surgery. They're typically performed by endoscopists, or what we call gastroenterologists with advanced endoscopy training. So additional training or experience in performing these types of advanced procedures. But there are surgeons that also perform these endoscopic bariatric therapies. Great advantages of these are that it has a very fast recovery and a very good safety profile, again, because there's no cutting involved, whether on the inside or on the outside. What does preparing for an endoscopy look like? Usually patients have tried some kind of weight loss program and not been able to achieve their goals. So some kind of diet and exercise or a combination of those, potentially with medications added. There may be a psychological or motivational assessment, typically performed by someone like me, but it could also include some mental health experts or psychologists or therapists. Patients will typically undergo an assessment by anesthesia to make sure that the anesthesia aspect is safe. These procedures are done with general anesthesia, but we have some excellent providers here that can make sure that you can get through that very safely. And then preparation is actually quite minimal. It's usually just nothing to eat or drink after midnight, the night before the procedure. You would come in, you get checked in, an IV line would be started. And then again, as we mentioned, you'd have general anesthesia. And typically this is an outpatient procedure, and it takes roughly about 60 to 90 minutes, depending on your own anatomy and which procedure we're doing. So now I'm going to talk about the endoscopic therapies that we perform here. And the first is what's called endoscopic sleeve gastroplasty. And so what this is doing is trying to mimic the same anatomy as the surgeons perform after a gastric sleeve surgery. And so what we start with is we do an assessment of the stomach anatomy, and we will make some marks on the front and back walls of the stomach to give ourselves a little bit of a roadmap of where we're going to put the stitches. We have a stitching device that we could attach to the end of our scope, and then we could bring this down through the mouth into the stomach and then start putting stitches into the front, middle, and back walls of the stomach. There's various patterns that have been used, and a little bit depends on your anatomy and what the interior looks like. And then once these stitches are put, they're kind of pulled tight and cinched down. And so the effect is that we're creating almost like an accordion or scrunching down of the outer wall of the stomach. And so this recreates that kind of tube shape that the surgeons do after the laparoscopic sleeve gastrectomy surgery. So we call this an endoscopic sleeve or endoscopic sleeve gastroplasty. We might put a few touch-up stitches to get it nice and narrow. And so the end result is that you have this tube-shaped structure in your stomach. So some real images. This is a normal looking stomach on the left. During the stitching process, the stitches are done and you can see that the kind of the midpoint of the stomach is scrunched down to make a very small opening, which will let food still pass. And then after the procedure is kind of nearing its completion, you now have this tube-like shape, and that makes it that you won't be able to eat as much, and therefore you lose weight because you are restricting the amount of calories that you can take in. Now, the ideal candidate for an endoscopic sleeve gastroplasty is someone with a BMI of 30 to 40 who's not a candidate for surgery, or you might have a BMI that may be higher than that and you do not want to undergo surgery because it may be more aggressive for you. When we think about what the expectations are, total body weight loss, when we look at longer term 5-year data, about 15 to 20% in particularly motivated individuals. And this is where we go back to that team concept that I was talking about, that by itself, the procedure is not the one and only thing that will help you achieve your weight loss goals. So it really has to be a team, and that may be your personal support system, it may be a dietitian, it may be medical weight loss experts and others. But as part of a team-based approach, 15 to 20%, or even greater for particularly motivated individuals. It's considered safe. Kind of the more common side effects are pain and nausea, which can be treated very easily. Pain and nausea are definitely expected the day of the procedure, but we provide medications to keep you comfortable. And then serious events are considered very rare. And endoscopic sleeve gastroplasty has been shown to improve other medical-related conditions, obesity-related medical conditions, including diabetes and the hemoglobin A1C, potentially as great as 1 point. Waist circumference, so bringing from 120 centimeter waist circumference to 93 centimeters, can drop blood pressure by 8 to 10 points. It's been shown to improve triglycerides, and has also been shown to improve liver enzymes in patients with fatty liver disease. So how does this compare to the standard of which is high intensity diet and lifestyle? So there was a study which took patients and half of them underwent the ESG procedure. The other half had a very kind of intensive, almost like a boot camp approach to diet and lifestyle, including counseling sessions, diet, other interventions like that. And when they compared the two groups, the ESG group achieved about 20%, 20 to 21% weight loss, and the high intensity diet and lifestyle achieved 14% weight loss. And this is in a very rigorous kind of research type setting. And the reality is that many people don't even achieve this on their own. 14% is actually quite high. And so ESG by itself, even without the high intensity diet and lifestyle, was quite effective. And so in order to achieve these numbers, again, if you combine the high intensity lifestyle and ESG, that's probably the patients that will achieve the most weight loss. I'm going to turn next to the second weight loss procedure that we perform. It's called a gastric bypass revision, or also called the TORI, or the transoral outlet reduction. And this is in patients who have already had that gastric bypass procedure, the Roux-en-Y gastric bypass. And what happens is that, as a review from before, that bariatric surgery, there's a pouch that's created, and then there's a bypass stomach. And over the years after the gastric bypass surgery, the pouch and the opening between the pouch and the small intestine where the surgeon had connected can get stretched out. And so instead of this pouch, which is supposed to restrict the amount of food that can be taken in, food can now go right through the pouch, right into the small intestine and become absorbed. And so patients might find maybe it's 2 years, maybe it's 5 years, sometimes it's even longer than that after a gastric bypass surgery that they're regaining weight, they're feeling full less later in the meal, so they're able to eat more, and they're feeling hungry more of the time. And so what we do with that same stitching device that's attached to the end of the endoscope, we will actually go in, find the opening between the pouch and the intestine, and either in this pattern or a different pattern that might go all the way around, we'll actually narrow down that opening. And then we could also work on the pouch. And so again, it's kind of scrunching everything down using endoscopic stitches and trying to mimic what your pouch or your what we call the stoma or the outlet looked like when you first had the surgery. And so now when you eat, you'll hopefully again have that sensation that you did after your original gastric bypass surgery, where you're getting full sooner and you're not able to take in as many calories as you were before. And this results in weight loss. So again, this procedure, the gastric bypass revision, is for patients with a history of a gastric bypass previously, and they regain weight because that connection between the pouch and the intestine gets stretched out, or what we call dilated. And that connection is called the stoma. So the stoma is too wide, or the pouch is too wide, and you're able to eat a lot more, and it regains weight. After the gastric bypass revision procedure, 5-year data suggests that 6 to 12% or more weight loss can be achieved. And again, this is the same concept of before, as this is on the fundamental of lifestyle, exercise, diet, and behavior change. The good thing about this procedure is that it can also be repeated. And so there is one version of this procedure where it's actually repeated every 3 months using cautery instead of stitches, and it can also achieve similar numbers like this. So here's an example in real life of the revision procedure. So this is kind of on the left, and around the outside is the pouch. And then this is the opening between the pouch and the intestine, which you could see through here in the middle. And this pouch is very wide. It should be much narrower than this. And so what we start with first is we'll actually cauterize the edges of the pouch, of the opening, of the stoma. And what this does is it intentionally kind of inflames the tissue. I want there to be inflammation, because inflammation means scar tissue, and scar tissue is what's going to help the stitches really take hold and help keep this thing down so it doesn't stretch out again. So after that, the stitching device is inserted. In this case, a stitch was placed around the outside, kind of like what we call a purse string. And then it's pulled tight over a balloon so it doesn't close off too tight. And then after the end of the procedure, you can see that the opening is actually just quite small. It's about 7 to 8 millimeters. So in terms of a before and after picture, this was the original opening, and this is a few months later, and you can see that there's a nice layer of scar tissue here that's made this opening much, much smaller. And so this is trying to mimic what was seen after the gastric bypass surgery originally. Discussing again the side effects of the ESG procedure and the gastric revision. Nausea and pain, typical, they're expected. We can handle them. Oftentimes patients don't need anything more than Tylenol or acetaminophen. We'll give you nausea medications as well. Less common, dehydration, or the opening becoming too tight. And that's about 3 to 4%. But the good news is that in most cases, either time will allow everything to stretch back out again, or if we need to, we can actually go in and do a little balloon dilation and gently stretch things to find that middle ground that's just right. One of the key advantages of these procedures over surgery is that the serious events, serious complications are very rare. And the need for reversal is also rare, but theoretically the stitches can be cut after we perform them. These procedures can be undone, and the other good thing about them is that it does not prevent future surgery. So if you're someone that's considering a surgery or considering a revision of your gastric bypass, it's often something to consider that you try one of these therapies to see if it can achieve your weight loss goals. And if it doesn't, then you can still have surgery in the future. I would just say that if you went to see a bariatric surgeon after having an endoscopic therapy, be sure that it's someone that understands where we put our stitches so that way they can work around them and be prepared and change their plan if needed. I'm going to turn briefly to the intragastric balloon, which is performed at some sites, and it comes and goes here at UCLA as we kind of evaluate the safety and efficacy data. But pretty straightforward. The idea is that your stomach is filled with one or more balloons which occupy space. And by occupying space, it means that you just can't eat as much. These balloons do not stay in permanently. They have to be removed typically after 6 months. But in that time, the idea is that hopefully you've lost weight and you've also kind of made those diet and lifestyle changes to help you keep the weight off after the balloon is removed. What can be expected, about 8 to 12% total body weight loss at 6 months. But when you look at kind of long-term outcomes, only about half of them kept that weight off at 1 year, and about a quarter of people keep the weight off at 5 years. And so for this reason, we're kind of doing a wait and see approach at UCLA on these intragastric balloons to see if there's a little bit more long-term data on how we can make it more effective, and not just the short term, but the long term. In terms of side effects, about 7 to 9% of people may experience some kind of side effect that requires it to be removed early. And the rate of adverse events or potential complications can be as high as 14%. But there's a lot of work being done on these balloons to make them safer and more tolerable. And they may be making a comeback here at UCLA soon. Now, after a bariatric endoscopy procedure, you can usually go home after an extended recovery. It may be a few hours, but it may also be an overnight stay. And really, that stay is to treat pain, nausea, give you IV fluids and make sure you're well hydrated. And we'll also put you on acid reflux medication, something like omeprazole or one of its cousins, just to make sure that you don't have any acid reflux type symptoms, and also to make sure that everything heals okay and you don't get any ulcers. We usually stop those after a few weeks or a month or so, as long as you're not having any symptoms. The diet is essentially the same as after bariatric surgery. So it's about 2 weeks of liquids, and then we slowly advance you to pureed foods, and then eventually to what your new diet is going to be. And the idea there is not so much that we're worried about a complication, but frankly, we just don't want those stitches to stretch out before they heal. And so letting that cautery take effect, letting that scar tissue set in, so that way the stomach, once we've scrunched it down, whether it's the pouch or whether it's a natural stomach and we've taken that outer curve and scrunched it, so it sticks and stays that way. And so if we went to a full diet too soon, it could stretch out the stitches. And so that's why we do a liquid and then a gradual advance. And you can imagine that that's a nice kickstart to the weight loss. And then we talk about landing on your new diet because, again, this is just one tool, and that kickstart is there to help you get to whatever the new diet and new lifestyle changes you and the rest of your team will make. And so ideally, we have a close handoff to the rest of the team, whether it's the medical weight loss experts, the dietitian, your personal trainer, etc. We'll do a clinic follow-up. And then in the case of intragastric balloons, it would be a 6-month endoscopy afterwards to remove it. Who are the good candidates for these endoscopic therapies? Well, it's patients that are motivated. And often by the time they're seeing someone like me, they have tried a variety of other things and are very motivated to lose weight, but just need a little extra help. Patients who can change their behavior. And so this goes back to what I was talking about earlier, where it's not just diet and exercise, but it's also the behavior change, your lifestyle, identifying those triggers, identifying where the calories might be coming in, etc. And as we've discussed a few times now, there's a big team and we can help. Patients have often tried weight loss programs and maybe have a little bit of success or not so much, and they need just a little bit more. And finally, it's those patients that, again, are not candidates for bariatric surgery because maybe the BMI is between 30 to 40, and so they're not covered by insurance, or patients who decline bariatric surgery because it may be too aggressive for them. And so in the closing moments here, I'll talk about this is just a snapshot of some of the data. And so we're looking at 1-year weight loss, 5-year weight loss, and then adverse events or complications. High intensity diet and lifestyle, about 14%. The sleeve surgery, the gastric sleeve surgery, weight loss of about 30% at 1 year, about 25 to 28% at 5 years. The balloon, 8 to 12% at 1 year, and we're still waiting on kind of longer term data. And then the ESG procedure, about 17 to 20%. And so you can see when we're really comparing, we're comparing the high intensity diet and lifestyle, which is very difficult to do for many people. And most people are not achieving this 14% weight loss with their diet and exercise regimen. The sleeve surgery, which is still strong and quite durable, but may not be right for everyone. And the ESG, which is, again, to fill that treatment gap. It's kind of the Goldilocks, not too tight, not too loose, kind of the just right type situation for many people. And long-term data suggests that highly motivated individuals can keep about 15% and sometimes even more weight loss out at 5 years. And then when we look at the safety rates, there appears to be an advantage for the ESG procedure with a much lower complication rate from the available data that we have so far. So to close, I'm just going to move on to a few therapies that may be coming in the future. One of them, which has shown some early promise, is this concept of duodenal mucosal resurfacing. It's another endoscopic procedure, and the idea is that there are areas in your intestine just past the stomach that may be responsible for causing diabetes, causing fatty liver. And what we can do is actually treat this by doing a very gentle burn with hot water. And when it grows back to healthy, it may actually have some benefit for diabetes, a little bit of weight loss, and a little bit of liver disease. And this is something that we're looking to study here soon. Other therapies that are out there are something called the Aspire Assist device, which is what's called an aspiration device. And it's essentially a tube that's put into the stomach. And after someone eats, a portion of that meal is actually vented in a very highly regulated manner. It cannot be kind of hacked or gamed. It has a very set amount. But the idea is that if you're taking in too many calories, some of those calories can be drained off. You can imagine there's a little bit of controversy about performing such a procedure or receiving such a procedure, but it does seem to be effective. Next is, we talked about that early part of the intestine, which seems to be very important. We just talked about that other procedure where it kind of burns this area, but there's also these devices which are sleeves that unfurl. And the idea is that there's no cutting or change in the anatomy, but food simply cannot touch the intestine because this sleeve is in the way. And that results in less absorption of food and potentially control of diabetes and other hormone related conditions. There's what we call the pyloric shuttle, which is another type of space occupying device that kind of blocks off temporarily the exit to the stomach. And so again, it helps you get full sooner and kind of motivates you to eat less. And then there's other types of procedures where we may actually connect different parts of the intestine. So a different type of bypass, which may be performed without surgery, where, for example, magnets can be used to connect one part of the intestine to a part much further down. So the food bypasses a large amount of intestine, and therefore you get weight loss by the malabsorptive process that we talked about earlier. And then finally, just as a reminder that these endoscopic weight loss therapies, they're safe, they're effective, but the fundamental aspect of all this is really the diet and the exercise and behavior change, that without those, the procedures themselves may only give you temporary benefit. And so it's always important to highlight that this is the foundation for everything we do. So in closing, the key points: obesity, hopefully I've convinced you, is a major problem. It's getting worse. There's a large treatment gap. Not many people are, and not enough people are being treated for obesity. And that not only includes the folks that qualify for gastric bypass surgery, but there's many people that are struggling with diet and exercise, which are potentially not enough. And they may need some additional help, whether it be medications or some kind of procedure. Diet, exercise, and behavior change are still fundamental. Everything we do is built upon that, and any one of the procedures that I've talked about today by itself may not give you the long-term weight loss without really these types of lifestyle and behavior changes. A multidisciplinary team is important. That can be your own support system. It could be some kind of commercial weight loss program, personal trainer, but there's also physicians, counselors, therapists, dietitians already here to help you achieve your weight loss goals. And then finally, we've discussed some of the safe and effective therapies that are already here. There's more coming soon. And for some resources on some of these options, I'll post them here. UCLA has a weight management program. We have the Center for Obesity and Metabolic Health, also known as COMET, which includes our bariatric surgery program, but also additional medical weight loss experts. And then my group, which is under the UCLA interventional endoscopy team, under the gastroenterology or digestive diseases, has some resources for obesity-related treatments with the bariatric endoscopy therapies. With that, I'd like to thank you for your time. Thank you for listening. And if you have any questions about the endoscopic bariatric therapies or really any other weight loss therapy, please don't hesitate to contact us, make an appointment, and we'd be happy to speak with you and discuss this further. Thank you so much.